It's really a great pleasure to be here in Tokyo this morning and to have a chance to speak with you about the future of HIV cure. This talk is really going to look very far into the future because except for 2 and possibly 3 individuals whom I'll discuss in my talk, we really don't have a cure for HIV, and we're only just beginning to appreciate both how difficult it's going to be to develop a cure that can be applied broadly, but also what is going to be necessary in order to cure the virus in a meaningful way from large numbers of people. This slide shows my disclosures. So why search for a cure? You've heard during the workshop to date about the remarkable advances that we've made with antiretroviral therapy and the incredible increase in lifespan for people living with HIV and the decrease in both the incidence of AIDS and AIDS-related mortality. So why do we need a cure? Well, I think as it should be obvious to most people in the room, antiretroviral therapy works only for as long as you take it, which means that for all infected individuals, people need to take therapy lifelong. There are concerns about the side effects of such long-term therapy and the potential for emergence of toxicities years or decades down the road that we may not yet be aware of. There's the burden of lifelong adherence to therapy, the cost of providing such therapy to tens of millions of people around the world, and serious questions about the sustainability of lifelong treatment on a global scale. We also know that even though antiretroviral therapy is highly effective, the persistence of the virus, even in its latent form, appears to be associated with inappropriate immune activation, and there's more and more evidence that this activation is responsible for end organ disease, such as the increased risk of cardiovascular disease in people with HIV, potentially also involved in CNS effects and other end organ damage. Should people stop therapy and virus rebounds, there's of course the renewed risk of transmission to sex partners or people with whom a person might be sharing needles. And then when you speak to patients living with HIV, the overriding factor in their desire for a cure is the stigma that's associated with HIV infection and the strong wish to be able to rid themselves of that stigma. So let me give you some definitions to help frame what I'll say for the rest of my talk. When I speak about the reservoir, what I mean are cells harboring replication-competent proviruses that can rekindle HIV replication or be responsible for transmission. So defective viruses, even though they might be important for some of the disease manifestations, really have no role in the reservoir, and unfortunately we tend to count them with some of our methods, and that adds to confusion about just how big the reservoir is and whether or not we're having an impact on the reservoir with our intervention. But the reservoir, properly defined, and as John Coffin would insist, is really only those cells harboring virus that could provirus that could generate infectious virions that can go on to infect new cells or new people. A latently infected cell is a cell then that harbors a replication-competent provirus but is transcriptionally silent as far as the virus is concerned. And because it's silent, there are no viral proteins that are being made. Therefore, the immune system can't recognize those cells, and those cells cannot be targeted for elimination. And that is the central challenge in attempting to eliminate the reservoir. So cells that are not latently infected, cells that are making virus or making viral transcripts, are not truly latent. They may be an important part of the reservoir, but they're not latent. So cure, logically, then means removing all of those cells, removing all the cells that have latent provirus that could lead to renewed infection. But short of an absolute cure, there could be long-term or sustained remission, a period of time, and nobody agrees yet how long this period ought to be for it to be clinically meaningful, during which patients would not require any antiretroviral therapy, but they would be free of viremia, no risk of disease progression, no risk of end organ disease, and no risk of transmission. Now that's a pretty high bar, but it may be more achievable than an actual cure where we've eliminated all of the potentially infectious proviruses. So by way of background, one of the reasons why there's such interest in the last 5 or 7 years in cure is that we have a much better understanding of the mechanisms of viral latency. We know much more about the anatomical and cellular nature of the latent reservoir. We have a much clearer understanding of the genetic structure of the proviral DNA. And the contribution of clonal expansion of latently infected cells to the persistence and maintenance of the reservoir. And then there have been the development of therapeutic approaches in other disease areas, notably in oncology and for some of the inflammatory immunological diseases, where these new therapies might be repurposed towards HIV cure. And I'll say a couple of words about that later in my talk. So this cartoon sets the stage about why we have viral persistence and what the challenges are. So here you see a happy, uninfected T cell. It encounters virus, and the vast majority of the time, the virus goes on to establish infection, is transcribed because the cell is activated, more virus particles are made, and the cell dies. But some of the time, a cell that becomes infected can revert back to a resting state. And in that resting state, the transcriptional machinery for HIV gene expression does not exist. The transcription factors have been sequestered. And so this cell no longer makes viral proteins, and as I said earlier, is immunologically invisible to the cells of the immune system. And therefore, this cell can continue to proliferate in a homeostatic way in response to antigen that drives its stimulation, drives its proliferation, and I'll show you some evidence for that in a moment. But what we've learned, and which is really very surprising, is that cells can undergo mitosis without necessarily activating viral expression. And that allows for this clonal expansion of these cells. Otherwise, you'd think these cells would all be eliminated as they entered into the mitotic cycle. And that is not the case. However, if the cell encounters the appropriate immunological signals, then it will become activated, and virus does get expressed and the cell dies. But there's still plenty of other cells remaining that have not become activated that persist. And it's being able to eliminate these persisting cells that is the central challenge of HIV cure. Now, we know from the work of Bob Silicano and Yachi Ho and others in their group at Hopkins that the vast majority of what we measure as the reservoir when we do simple proviral DNA quantification is actually defective virus, and that's shown in these large outer shells here. And the reservoir size varies from person to person, but the actual amount of virus that can be recovered by stimulating the cells in the laboratory and trying to grow virus is a small fraction of that total amount, and that's shown in the inner yellow circles. And then there's an intermediate group of proviruses from cells that may not be readily activated in vitro, but when you sequence the virus, it appears to be completely intact. And some experiments where those proviral sequences have actually been inserted into a appropriate backbone generate fully infectious virus. And so from person to person, the proportion of intact proviruses and culturable provirus varies, but is a minority of the total number of sequences counted by PCR. And that generates some real challenges in knowing whether we're having an impact on the reservoir when we intervene. This slide shows some data from work done by Tim Henrich when he was a postdoctoral fellow in my lab. He's now an associate professor at the University of California, San Francisco. And here what we did was to take cells from people who had undergone chemotherapy and whose reservoirs had initially shrunk but then re-expanded as their counts recovered following chemotherapy, typically for lymphoma or for other solid tumors. And the cells were stimulated in vitro by a mixture of Epstein-Barr virus and cytomegalovirus, EBV and CMV antigens. And then the cells were sorted based on whether they had responded to these viral antigens, and that we sorted them on the basis of their production of interferon gamma. And after the cells were sorted, we then PCR'd the cells to determine whether they harbored HIV provirus or not. And so in this slide, there are five different participants whose data are shown, and each pair here shows first the percent of CD4 cells that responded, and you can see that a minority of cells respond to the viral antigens by producing interferon gamma. But then after we sorted them, this small proportion of cells harbored all of the proviral DNA. You can see that the non-responding cells were negative for HIV DNA. Similarly, in this participant, only 10% of the cells were responsive to EBV and CMV, but those were the cells that harbored proviral DNA, and so on. And that suggests that the reservoir is expanding because the cells are seeing their cognate antigen, the antigen to which they're programmed to respond. They happen to carry provirus, but they're stimulated to proliferate in response to this antigen, and that causes this expansion. And other work done by John Lee in my group and by John Coffin and Frank Maldarelli and John Mellors and many others has proven that these are, in fact, clonally expanded cells. So that brings us then to the central dogma for HIV cure, which is that a combination of approaches is going to be required. First, to reactivate the cells in order to allow for HIV gene expression so that viral proteins will be expressed on the surface of the cell, making them visible once again to the immune system, but then also stimulating HIV-specific immunity and overcoming the barriers to killing of HIV-infected cells by cells of the adaptive immune system and potentially harnessing the innate immune system as well, driving those cells into the germinal follicles where these reservoir cells are persisting in order to eliminate them. And several different strategies for immune stimulation, including therapeutic vaccines, the use of broadly neutralizing antibodies or designer T cells, immunologic agonists, and checkpoint blockers have all been proposed as approaches, and I'll show you some data from several of those. So, as I was just saying, approaches to HIV cure have included cell-based therapies, such as allogeneic transplantation of hematopoietic stem cells from donors that lack a critical co-receptor for HIV, the CCR5 receptor, or alternatively, gene editing of autologous stem cells or mature peripheral CD4 cells in an attempt to reconstruct a population of cells that would be genetically resistant to HIV infection. Latency reversal is another key approach. To date, this has not been terribly successful, and I'll summarize some of those approaches in a moment through the use of histone deacetylase inhibitors or toll-like receptor agonists. Several different immune-based interventions are in early phases of trials, including checkpoint inhibitors, therapeutic vaccines, and then broadly neutralizing antibodies. And there have also been attempts to limit the size of the reservoir by very early initiation of antiretroviral therapy, including immediately after birth in the small number of infants still becoming infected, despite effective mother-to-child transmission prevention campaigns, or in adults who are recognized as having acute HIV infection. And I'll show you one very intriguing example of that, again, from my colleague, Tim Henrich. So, allogeneic stem cell transplantation to date has been the only successful approach to cure. And the very first cure was that of Timothy Ray Brown, the so-called Berlin patient, who now more than a decade ago underwent stem cell transplant because he had developed acute myelogenous leukemia, or AML, after being infected with HIV for many years. He had been on a stable antiretroviral regimen, but had interrupted his ART regimen to undergo chemotherapy, and you can see how virus came rebounding back swiftly when treatment was stopped. He then went back on treatment, had a relapse of his leukemia, and so he had to have a stem cell transplant. Now, fortunately for Mr. Brown, He had a hematologist, Gero Hutte, who had the foresight to think maybe we can find a matched donor who is missing CCR5, and those cells should be resistant to HIV infection. And they, since 10% of Northern Europeans are heterozygous for this deletion, 1% of people are lacking the gene entirely or are homozygous for the deletion, and there's no ill consequence to their health for being CCR5 deleted. And so they were able to identify such a donor, and you can see that from the time of transplantation, therapy for HIV was stopped, and there's no virologic rebound. Remarkably, there was actually a relapse of the leukemia, and the hematologist was able to go back to the same donor and do a second transplant with the same CCR5 deleted cells. And this time, the leukemia was cured, the transplant took, the patient became 100% chimeric, meaning all of their circulating immune cells were now of donor origin. And now, as I said, more than a decade later, Timothy Brown remains free of HIV, and he now goes around the world speaking about his experience. Now, this approach does not always work, and one reason it might not work is because there are two kinds of HIV that can circulate, the type that uses CCR5 exclusively, and another kind of HIV that derives from these R5 viruses that evolves to use the alternative co-receptor CXCR4. And Monique Nijhuis in Holland has reported on the Essen patient, another person who had a hematologic malignancy who received a stem cell transplant with a CCR5 deleted donor, but after stopping antiretroviral therapy, the patient had prompt rebound of their virus, and then in retrospect, they were able to go back and determine that actually prior to the transplant, the patient had a minor population shown in the smaller red circle of virus that used CXCR4. And all of the virus that was rebounding after the transplant was this X4 virus. And so the attempt at cure here failed because the patient had the wrong kind of virus. And this is an important lesson. Now, we had some interesting patients in Boston who had relapsed lymphoma and received stem cell transplants from healthy donors who were wild type for CCR5. We started following these patients after their stem cell transplant. They had, what was unique about these patients at the time is that in the United States, most individuals undergoing stem cell transplant had to stop their HIV therapy because of drug-drug interactions with either the chemotherapy or the immunosuppressants used to prevent graft versus host disease. But with better antiretroviral drugs becoming available, the oncologists at the Dana-Farber Cancer Institute were able to continue our patients on ART throughout the transplant period. And so for this particular person who had a relapsed lymphoma, you can see that just prior to the transplant, they still had readily detectable proviral DNA in their circulating lymphocytes. And this is despite having had numerous rounds of chemotherapy, a failed autologous stem cell transplant, so there is still persistence of the reservoir. They received this donor transplant from wild-type donor, continuing on antiretroviral therapy, so there's no viremia. But then when we started following the patients again, we see no detectable proviral DNA. And then nearly 2 years later, even after doing a pheresis where we took large numbers of cells, did multiple rounds of PCR, multiple attempts to recover a virus by outgrowth assay, even a rectal biopsy in an attempt to define mucosal reservoirs, we couldn't find any evidence of persisting virus. And so we then cautiously stopped antiretroviral therapy, and quite remarkably, for about 200 days, there was absolutely no recurrence of virus. I should mention that because this patient now had a new immune system, he also had no HIV-specific immunity. There were no CD4 or CD8 T cell responses. So this is not immunological control of the virus. This is pure virologic latency. Now, unfortunately, after day 200, the patient called a few days later to say, gee, I'm not feeling well. I'm having fever and muscle aches and a headache. And we said, go and get another virus load test. And what happened was he was experiencing virus rebound. He was put quickly back on antiretroviral therapy, and we were able to once again control his viral infection and get him back down to undetectable. But very clearly, the absence of any detectable virus in the peripheral blood and even in the rectal mucosa did not mean that there wasn't some virus hiding someplace. We just couldn't find it or get it sampled clinically. So this is a very complicated slide to read, but I'll just quickly summarize it for you. Another very similar patient is a person who was just starting PrEP. At his screening visit was HIV negative, but then the sample was sent for HIV RNA testing, and it turned out he was positive, and he had just 200 copies of HIV RNA. So he had started off on tenofovir FTC, and then his regimen was immediately intensified by the addition of an integrase inhibitor and a boosted protease inhibitor, and so virus replication was halted immediately and then sustained for more than 2 years, during which, just like the Boston patient, there was no evidence anywhere in his blood or in his tissues for persisting HIV. And Tim Henrich was following this patient now out in San Francisco. So they stopped therapy, and just like the Boston patient, this person went about 200 days. No immunological control, because there was no opportunity for an immune response to develop in this patient since antiretroviral therapy was started so quickly. But again, after about 220 days, the patient experiences relapse, once again showing that just because you can't find the virus through clinical sampling doesn't mean there isn't persisting virus somewhere in a long-lived reservoir. The same was true of the Mississippi baby, a baby whose mother did not get appropriate prenatal care. The baby was born with HIV infection, put on treatment right away, and had suppression of their viral replication. But then the baby and the mother disappeared from care for several years, and when the baby was again followed, then there was no evidence of relapse for nearly 4 years until there was a relapse, again, very much like the San Francisco and the Boston patients that I showed you. And the more encouraging example of that is this one patient from the SHARE trial reported by Violari and colleagues, who now, a decade after having gone on very early antiretroviral therapy, appears to remain free of relapse. So long-term remission does seem to be possible. And at at CROI a couple of months ago in Seattle, we heard the encouraging report from Ravi Gupta of the so-called London patient. I think they missed the opportunity to call this the English patient, which would have been a real, anyway, this is a person very much like the Berlin patient who had relapsed malignancy, received a stem cell transplant from a CCR5 deleted donor, and after 3 years or so, they decided to stop, after about a year and a half, they decided to stop antiretroviral therapy, and now a year and a half later, the patient is still free of any recognizable or detectable HIV, and that corresponds to the fact that the person is fully chimeric. His entire immune system, all of his T cells are from the donor, and they all lack CCR5. So what have we learned from this experience? Well, clearly it's possible to reduce substantially the reservoir of latent HIV in certain patients. And in the setting of an allogeneic stem cell transplant, we believe that this reduction is most likely mediated by immunologic mechanisms such as graft versus host. It's certainly not the chemotherapy. Our patients received a reduced intensity conditioning regimen, and we showed the persistence of the reservoir despite numerous rounds of chemotherapy. So it's really the donor cells attacking the host cells and eliminating them, not because they carry HIV, but because they are foreign to the newly transplanted stem cells and the T cells that come along with that, and they happen as a bystander effect to be eliminating the cells that carry HIV. Reducing the reservoir in this fashion dramatically prolongs the time to virologic rebound. And it also teaches us that even in the absence of an effective HIV-specific immune response, latency can be maintained, but that virus can persist in reservoirs that are inaccessible to clinical sampling, and reactivation of these rare latently infected cells is sufficient to cause virologic relapse. We also learned the important lesson from the Essen patient that minority X4 viruses can relapse in the context of homozygous CCR5 deletion. So this led Alison Hill, who is a very talented mathematical modeler and biologist, to construct some hypothetical curves about what would it take to have lifelong remission. And what she shows here is that if you achieve about a 3 log reduction in the reservoir, which is what we achieved in the Boston patients, then about half of patients will relapse within a year, and all will have relapsed within 3 years. It would require a 4 or 5 log reduction to have a 30-year remission and a 6 log reduction in order to have reliable lifetime remission of HIV, or essentially cure. But we can't measure a 6 log reduction because there's just not that much reservoir to measure in the blood. And so we're really shooting in the dark when it comes to this. Now, a very interesting experiment was done by Afam Okoye at the Oregon Primate Center, and these are the only non-human primate data that I'll show you. They took macaques that they infected with SIV, treated them with antiretroviral therapy. When they were fully suppressed, they then depleted their CD8 T cells, the cells responsible for HIV-specific cytotoxic T cell activity. And during the infusion of this anti-CD8 antibody, they stopped antiretroviral therapy. And so you would think that if T cells play an important role in controlling HIV, that these animals would relapse more quickly, having had their T cells depleted. And in fact, exactly the opposite was found. There was no difference at all. You can see here the time to relapse in the group that got a control immunoglobulin versus the group that got anti-CD8 antibody was identical, as was the rate of reactivation. What did differ was the magnitude of the viral rebound. So here again, you can see no difference in the time to rebound, but the animals that had their T cells depleted, had no CD8 cells, had 2 logs more virus at steady state than the animals that got the control immunoglobulin. And so what this teaches us is that reservoir size is the determining factor in time to viral rebound. CD8 T cells, at least in this setting, do not appear to alter the timing or the kinetics of rebound, but they limit the extent of rebound. And so approaches aimed solely at enhancing HIV-specific T cell responses, such as therapeutic vaccination, are unlikely to prevent viral rebound, but enhanced immunity might still be important for containing viral rebound when it does occur. And this has important implications for how we design clinical trials in order to test some of these interventions. So let me run quickly now through a couple of different approaches to cure. Cell-based therapies are genetically modified cells. We've learned that these are generally safe. The cells persist, and they can even be enriched during treatment interruption because they have a selective advantage if they're resistant to virus infection. But it's been very hard to achieve a consistent high level of gene knockout. And remember, you have to knock out both copies of the gene. And usually it's not more than 25% of the cells that carry a double knockout. And it's also unclear how these genetically modified cells are going to eliminate the reservoir. They'll be protected from being infected themselves, but they're not going to touch the reservoir. So the question remains whether the Berlin and London patient outcomes can be replicated using genetically engineered autologous cells, and whether it's sufficient to introduce a population of cells that are resistant to the virus, or whether we have to couple gene editing to some other strategy for eliminating the latently infected cells, and then we have to worry about to what extent pre-existing X4 variants, such as in the Essen patient, are going to impede or circumvent this approach. Latency reversing agents, such as the HDAC inhibitors, have been tried in several different studies. At least 3 different HDAC inhibitors have been tested. And at current dosing regimens, these drugs have been very slightly effective at reactivating the latent reservoir. And if in the laboratory, maximum stimulation only reactivates a fraction of the cells that harbor intact full provirus on any given day, then multiple rounds of stimulation are going to be needed in vivo in order to activate the entire reservoir. And it's highly unlikely that reactivation alone will suffice to deplete this latent reservoir. So we have to find safer, more effective approaches to reactivating latent provirus. We don't know how many cycles are going to be needed. If if there are cells that we simply can't induce, maybe it's best to let sleeping dogs lie and not worry about those cells that can't be woken up. Maybe they won't ever wake up, but there's no way of proving that. And then we don't know how to cycle reactivation with immune approaches in order to get the best effect of these combinations. Well, what about immune-based therapies like checkpoint inhibitors? The ACTG did an abbreviated study of one such approach with an anti-PD-L1 antibody. We had to stop the study because of toxicity that emerged in monkeys. We're now just about to launch a second study using an anti-PD-1 antibody, cemiplimab. But what you can see is that in the 6 patients who received the anti-PD-L1 antibody, 2 of them had significant increases in HIV-specific GAG activity as measured by interferon gamma release. We didn't see much of a change in the reservoir, and the sample size was really much too small to draw any meaningful conclusions. A bigger study in patients with cancer who received pembrolizumab was reported at CROI, and you can see there were increases in unspliced RNA suggesting that there was activation of virus, and there was an increase in viral RNA in the plasma, but no change in the proviral DNA or in the reservoir itself. So we've seen encouraging data from non-human primate studies, limited human trials to date. These drugs are toxic and have autoimmune effects that are quite concerning, and regulatory agencies have shown appropriate caution in approaching trials of these agents in healthy HIV-infected persons, and so the risk-benefit ratio remains to be defined. There's continuing interest in exploring immunomodulator therapy in pilot studies and in exploring combinations, but combinations may be a double-edged sword. They may have greater efficacy, but also carry the risk of greater toxicity. And it's going to be important to confirm in human studies the promising results from preliminary non-human primates studies. Therapeutic vaccines have been tried for more than 2 decades, and nearly all vaccine candidates have demonstrated good immunogenicity, but the encouraging results seen in non-human primates have generally not translated into humans. There have been only modest effects on post-vaccine control of viremia in the human studies, no consensus at all on what constitutes a correlate of vaccine efficacy, and no systematic approach for building on previous trial results. So we need to define the endpoints for these vaccine trials, define correlates of activity, and have a sustained focus. Too often, by the time the trial ends, the vaccine has been abandoned, and there's no new supply of vaccine to be able to make the next generation of that vaccine in order to improve on the responses. And so we need clear long-term objectives and clear go, no-go criteria. So lastly, we need to rethink the role of treatment interruption in assessing the impact of these interventions. We know that treatment interruptions can be done safely with appropriate monitoring, although there are hypothetical risks of primary infection syndrome, the risk of transmission to sex partners, and the risk of reseeding the reservoir. The time to rebound and viral set point are very different endpoints, and as you saw from that experiment in the monkeys, depending on the type of intervention, we might have to be looking at viral set point, not just at time to viral rebound. Whether we can do a treatment interruption in participants in the trial who have received a control intervention is a challenging question, and when and how to restart treatment is another issue. Now, one encouraging bit of information comes from work that John Lee in my group has published, where you can see that there's really no change in the viral reservoir pre and post ATI. So that is, after people went back on therapy and were resuppressed, their reservoir was essentially the same size as it had been before. So we don't really have to worry about expanding the reservoir during treatment interruption. So let me end by leaving you with some unanswered questions. What is the minimum clinically acceptable duration of a drug-free remission in order to call it a remission that is worthwhile attempting, and what risks would be tolerated to get to that remission? Are remission and cure sufficient to return the pro-inflammatory state to normal, and will this reduce the risk of non-AIDS clinical events? How can we determine if the effect of remission or cure on the risk of transmission, especially mother-to-child transmission? And at what point can we equate sustained remission to actual cure? So with that, let me thank all the people who contributed to some of the data that I showed, and thank you for your attention. And if there's time, I'm happy to answer some questions.